Hello everyone, Shaun and Bo here back again to have a chat with you today about trigger points. Bo, this is a big one. We've been holding off on this topic. Yeah, it's one of those areas that you could talk about for days, and then by the time you finish talking, there'll be some new research to refute everything you've just said. It's a funny one too because there's still a lot of people out there that are disputing that trigger points even exist. They're saying that if you can't measure it, then it doesn't exist, but we do know that you can measure it, so we'll talk about that. The pathophysiology is super confusing and complex, and then how we treat it, there's multiple layers of that, and then understanding around how that all works as well. So it's a big topic, right?
Yeah, absolutely. And there's, like everything that we do, it's far more complex than we initially think. There's so many factors that can contribute to the formation of trigger points, the influence of pain. So yeah, I think we really need to not only look at the trigger point, but outside the trigger point, as far as central mechanisms and environmental factors as well.
Yeah, and I think the old school thinking around trigger points was that it's just a tiny little cramp in a muscle, and it's as a result of stress on the body. It's a very external focus. It's very much, you've worked too hard, the muscle's tightened up, you've got a local spasm, just a little cramp. If you stretch that out or squash it or stab it with a needle or whatever other technique you might like to use, then that cramp goes away. But there's a lot more to it than that, right? We've got to consider multiple systems in this.
Yeah. Well, what about the patients that are uninjured or they don't do physical activity, so they're not causing any damage to that myofascial unit, yet they still present with trigger points and myofascial pain?
And satellite trigger points, that happen in peripheral areas that aren't necessarily related to any load or other factors that might be applied to the location of the primary trigger point. So that sort of adds, I think, complication to the whole story, because not only do we have different theories about how trigger points develop, but there's also different categories of trigger points, and then one theory doesn't necessarily work across all those categories. So it's a tricky one.
Definitely. And another interesting thing is where, I guess the understanding is that it's a tight muscle that forms the trigger point. Well, if we look down at more of that microscopic level, there could be a taut band or a short muscle fiber within a long muscle. So you look at your typical upper trapezius trigger points, they're not with their shoulders up around their ears. They've typically got these long, depressed, loaded muscles. So as a whole, that muscle is in a lengthened position, yet we can still find those ischemic taut bands, those exquisite palpable nodules, if we go by the definition, within that muscle. So it can be that there's that restriction of that muscle fiber, but then other fibers are at length around it.
You're right, and it's often we see trigger points present in fatigued muscles, muscles that aren't holding even an appropriate amount of tone, and that can be as a result of poor health of that tissue potentially, as opposed to an external load that's put on it.
Absolutely, and weakened muscle, that's another one where we think, well, there's pain in it. That the first response is to stretch it, make it longer, but we often need to get that health in the tissue through improving blood supply and strength, give that tissue more resilience to be able to withstand the forces of demands that's placed on it. So it may seem a little bit counterintuitive, but that's where we can really implement manual-therapy techniques to take away some of that pain, to allow them to get stronger and prevent that trigger point from coming back. Yeah. Because they're not just appearing out of the blue for absolutely no reason. We've got to identify why is that trigger point there, and what can we do to stop it from coming back.
That's a really good point. I think we often look at things through through blinkers. Someone comes in with trigger point pain in their rhomboids, for example, and we go, right, well, obviously those muscles are tight because we've been hunched over the desk all day. So we can go and apply lengthening techniques, stretching techniques, things that would soften and lengthen tissue, ideally. And then as a result, you have there's more length applied to that muscle, and where in actual fact, you might be right. They might need a greater degree of strength. They might need increased tone in those muscles. But if the person presents to us with trigger points there, and we ignore those and go straight to strength protocols, then they won't be compliant because it will be painful. They won't get the results they want because they won't do the work they need to do. And so really, that's kind of the key thing with trigger points is they hurt. If a person comes in with a trigger point, regardless of where it is, what the state of the tissue around it is, we need to address that point of pain, because not only will it improve compliance, but pain itself can be a major issue when it comes to chronic presentations. If we don't address the pain in the short term, it can very easily become a chronic presentation that goes beyond the trigger point, beyond the tissue, into more of a central type problem. And we've had discussions previously with Dr. Jay Shah about this. And he's a big advocate for address the pain fast, address the pain early, do it as quickly as you can in whatever way you can, and then address the tissue problem. Because you don't want it to become a central sensitization or some kind of ongoing chronic presentation that you can't easily impact.
Yeah, definitely. And that's the thing. It can be caused by central mechanisms, or it can be caused by peripheral mechanisms. And that's where this loop can continue. So I guess if we had a look at what's happening in the periphery, or why that particular point is painful. So if we've got a change at that cellular level, so we've got that contracture of the sarcomeres, so stuck in that shortened environment, well, then we start to have compression of local blood vessels, local nerves, which then can send more of these danger signals back to the central nervous system. But there's also various chemicals that are released. So that inflammatory soup, we can have neurogenic inflammation. So inflammation that sort of is released from the nerves, that's substance P, calcitonin gene-related peptide. Now, these are sensitizing chemicals, which means that it's much easier now for a message to be sent back to the spinal cord. So I think it's interesting when we start to look at it that way. There's a range of other sensitizing neurotransmitters. But even when we look at muscle contraction, now acetylcholine is a neurotransmitter that we will all be well aware of as far as muscle contraction. But there's certain sensitizing chemicals that can inhibit inhibit, if I can talk properly, acetylcholine esterase. Now, acetylcholine esterase actually breaks down acetylcholine. So if we've got more neurogenic inflammation, which means we've got more calcitonin gene-related peptide, that can inhibit acetylcholine esterase. Now, that means that we're going to have more acetylcholine in that environment. So that can create this muscle contracture, a sustained muscle contracture. So you can see how that might become more of a chronic problem. If we've got more neurogenic inflammation, we've got this acetylcholine that's not being broken down. So we've got this sustained muscle contracture. We also get that lowering of the threshold to create an action potential. So to create that, allow that the nerve fibers to send a message back to the central nervous system. That happens much easier. And one of these chemicals is norepinephrine. Now that can open up more channels to allow more sodium to get into that cell. Norepinephrine is a stress chemical as well. So you think of those people that are highly stressed, they're in that fight or flight sort of environment all the time. Well, increased levels of norepinephrine is allowing more sodium to go into that neuron to initiate that action potential. All right, so now we've got an environment where we've got these inflammatory chemicals, which is now easier to send a message to the central nervous system. There's an inhibition of chemicals that break down acetylcholine. So this sort of pain spasm can really continue, which is frustrating. It's painful. There's an emotional response. So it can be quite a nasty environment with myofascial pain. Not only that, when we look at that as just one trigger point, the more prolonged this is, you start to get this expansion of the receptive field. So now there's widespread pain that starts to sort of spread out into, you get this axonal branching onto other neurons. So now that noxious input is detected from a larger area, which is all then sent back to the central nervous system.
Yeah, that's what people come in and they'll say, my back hurts. Where? Oh, just my whole back. And then you dive in there with your thumb and you go, how's that? And they go, oh, that's the center of it. That's the spot. Yeah, and then you've got this axonal overflow that goes out, and you've got pain in an area as opposed to a locus. And this is the danger of not treating exquisite locus pain, local pain in the early stages, because you get this overflow effect, and it becomes a cascade of problems that sort of like set of dominoes. So you have to address it quickly.
Look at that in an unhealthy tissue environment of, okay, well, I've got sore upper trapezius, and then that gets worse. You're not doing anything about it. You're not exercising. You're not moving. You're not strengthening it, whatever it may be. That spreads, but not only in the periphery, because we're getting this constant bombardment back to the dorsal horn, it can sensitize the dorsal horn. So you got your peripheral nociceptor, right? As that goes into the dorsal horn, it then synapses. So you got your primary or your first order neuron, and then it synapses with a second order neuron, which then goes up to the thalamus and synapses with a third order neuron. Mm-hmm. So if we have this peripheral sensitization, so that's the nociceptors, let's say, as you can see in my forearm, I'll use upper trapezius again, that area can be sensitized, but so can the spinal level where that nerve is actually going into. So that's where it becomes a central problem. And then you can also get that overflow, the segmental overflow. So any area that's innervated by that particular nerve root, whether that be muscle, joint, connective tissue, ligament, that can all be affected. But then if it goes up or down to the next segment, then any tissue that's innervated by that level can be affected.
Yeah.
So you can see how pain in general could start as a peripheral input that sensitizes the central nervous system, to then even know that we've taken away that peripheral driver, it can be now a central problem, which can then spread up and down, and then it can be quite challenging and frustrating, because people may go for imaging or no one can find out what's wrong with me. They looked at my scan, or scan said there was nothing wrong with me, but it's painful. So we've got to think, well, there's more of a central problem going on here, and that's where the complexity and the challenge really comes into it.
But it's also really useful to understand that mechanism. So we understand that there's a peripheral isolated problem initially, potentially isolated. It then can become a central issue, which then has overflow out back into the periphery and up into the brain and through the spinal cord. There was an interesting study. Remember that discussion we had with Dr. John Serbley about the study he did around pain pressure threshold testing of trigger points. And he found that using this model of understanding, that if he was to treat a trigger point in a muscle, and there was trigger points in other muscles that are supplied by the same nerve, by the same spinal segment, that when he treated that one trigger point, other trigger points' pain pressure threshold would diminish also. So he treated, I think in his study, he talked about a trigger point in a supraspinatus, which the nerve that feeds that also feeds the infraspinatus. He did pain pressure threshold testing. You apply a device and there's a certain rating about how much force you have to apply to the trigger point to elicit pain. So he treated only the supraspinatus, but then after the treatment, its pain had reduced, but also the infraspinatus trigger point had also reduced. And this was consistent across different segments. And so that tells us that a trigger point is not isolated. It's not an island in your tissue. It's not sitting there by itself. It's definitely connected via the nervous system. And then if we understand that mechanism, we can apply that. If someone comes in with trigger points all through one area of the body and all through another area, we know that they're supplied by the same nerve root, well, then maybe we don't have the time to address all of them, but we can address one and have an overflow effect into the other. And so this is why understanding pathophysiology, mechanisms with manual therapy, and then combining those two things, you can start to apply your clinical reasoning over the top of that, save yourself time, save yourself excessive intervention with the patient, and potentially, say that within inverted commas, get a really good beneficial effect for that person.
Yeah, absolutely. And I think even looking at what we do with our treatment techniques, whatever that may be, if it's a deep ischemic pressure, dry needling, just a general massage, whatever it may be, we looked at what's happening at that cellular level, at the sarcomere, the contracture, the biochemical milieu, or the inflammatory soup around that area, which can be a noxious environment. So you get a decrease in pH. So we've got these cellular changes which affect the central nervous system. Unhealthy tissue because we're getting loss of oxygen, a loss of blood supply, and blood and oxygen is what feeds that area with nutrients. Okay, so that's what's essential for the health of it. So if you think about even explaining that to a patient that way, that that your lower back may not be damaged, it may be unhealthy, and how do we get tissue healthier? It's no different to diet and exercise. We get things moving, we put better nutrients into that area. So if we think of it, explaining it like that it will respond really well to movement. Massage can be a great one in the short term to reduce some pain, but we need to get that healthier long term. So when we apply a pressure or a needle to that area, well, what we're doing is we're actually stimulating local capillary dilation. So we're getting more blood flow, more nutrients into that area, which can then change the, I guess if we've got an acidic environment, we add more blood flow into the area, it dilutes it. So now it's less acidic, which means then those nociceptors are no longer sending these danger messages back to the central nervous system. So we get a change in processing, change in output that can relax. So what we do with our hands can be certainly one effect, but even the benefits that we have on the central nervous system can be massive. As I said before, with increase in stress hormones that can make it easier for those pain signals to be sent. Lowering that parasympathetic tone to put them in more of that sympathetic environment, we can really start to relax that person and create some really good changes to stress.
Yeah, and if we apply those sort of ideas then to clinical practice, it's really interesting, and it's kind of a little disheartening probably for those who are like us who are very much invested in manual therapy, and we're huge advocates for it. You'd probably struggle to find two people that are bigger advocates for manual therapy. But when it comes down to these mechanisms at play, it almost doesn't matter what we do to that tissue, as providing we apply an appropriate non-noxious stimulus to the tissue. A lot of those processes will be triggered. You could apply a needle, you could apply basic ischemic compression, you could apply a heat pack. You can just rest your hand on their back and apply gentle pressure, and you'll still get some vasodilation. You'll still get some releasing of those endogenous opioids. There'll still be these changes in the chemical processes, and a reduction in pain as a result of that happening at the spinal cord. And that's why I say it's sort of disheartening. Yes, certain manual therapy techniques will probably produce more direct effects faster. But I think a lot of the time we get lost in the specificity of it all. We don't have to be as specific. I remember learning trigger points years ago, and we were taught you had to hold the trigger point for a certain amount of time. Why? That there's no science to support that as a concept. Far better we hold it until the symptoms change. That the patient reports some changes that are appropriate and that feel beneficial to that person. Because if they feel like they're receiving benefits, then that also kicks off emotional changes in that person's state, which then supports some of that pain modulation. So there's, it's probably not as complicated as we make it out to be in a lot of cases.
That's right. And it's just creating that window. What we do in our treatment setting creates a window, and like you said, it could be a range of techniques you choose. Whatever it is and whatever works for that patient, because what works for one might not work for another.
Mm-hmm.
That's why we do have to have a tool bag of different techniques, but also what we do, what we say, how we can build trust and rapport, all really influence into that therapeutic relationship and the outcomes. But whatever it is to get them to a point where there's a window where they can then remove or modify those lifestyle, social, psychological factors, whatever else may be contributing to why they have that pain or why they have that trigger point.
Exactly. So sum it up now. If we're talking about trigger points, the key takeaways from this discussion would be trigger points, they're not an isolated local phenomena in tissue. They are perceived that way, they feel that way to the patient, and we can palpate something that feels like a little nodule in the tissue, and that exists because people have taken biopsies of trigger points and they've found that there's a different chemical makeup in that tissue versus the tissue that's even a few millimeters adjacent to it. So the trigger point does exist. We can measure it in that way, but it's not isolated in that it's not that it's not connected to the rest of the body. Our nervous system and our, there's neurological, there's chemical processes that take place for it to occur, and then there's neurological and chemical processes that are triggered as a result of it as well. Yeah,
definitely. And even, looking at a trigger point in the periphery, what segment at the spine is that coming from? So say if it's biceps, have a look at C6. If it's a persistent trigger point, well, it's creating more noxious input to C6. Is there changes at C6 that need to be addressed as well? So yeah, really looking peripherally and centrally, and encompassing the whole sort of pain neuromatrix, not just purely that physical presentation.
We did say it was a big topic, didn't we?
Massive.
All right, that's good. We'll leave it there. Thanks for that.
Cheers.